Great. Thank you so much, Laura, for that introduction. And thank you so much for all of you for attending. We have people from far and wide, and it's very exciting to have so many of you here. So we've been waiting a long time to be able to make this presentation. And before we get started, I would like to acknowledge Michelle Dukeman, who's on the call with us, and Jessica Kasten, who couldn't be. Without their assistance, this project would have been either not possible to do or would have been near impossible. So really want to give a big shout out for their unwavering help and dedication to the project. Daniel is on the call with us, and Jesse McLean, I'm hoping is able to join us. He is the site investigator from RVH who has participated in the project with us. So as Laura mentioned, this began as a project with Waypoint in Georgian when COVID was we were first coming to understand what it might mean to us as healthcare providers and what the pandemic restrictions and all of the changes to the health system, the disruption that was occurring. Never in our dreams did we think we would be here at the end of the project in the third wave of the pandemic. But the one thing that we did know is that we would need to start thinking about the pandemic recovery. We understood early on that the pandemic and the concerns for contagion, the impact this would have on the lives of healthcare providers would be very disruptive and would cause quite a lot of psychological harm and quite a lot of disruption in the lives of patients and healthcare providers. So we really organized this study with the pandemic recovery in mind. And we're sure pleased that we did this because we're hoping that what we present to you today gives you some new perspectives, some new insights that can hopefully guide you as you think about moving through this, hopefully third and final wave of the pandemic, and as we move into pandemic recovery. So we've really enjoyed our partnership with Waypoint and RVH in Georgian. It's been really I think a really great example of collaboration across sectors, using different talents, using different perspectives to organize a study such as this one. So I'm going to turn it over to Nathan. And now that I'm sharing my screen, I can't see the chat. So just wanted you to know that after the organizers. So I'm going to move to the next slide, Nathan, and you'll talk about our research questions, please.
Great, and let me just echo Jacqueline's thanks for everyone's attendance today. It's been a real pleasure from my side and Waypoint's side to be able to collaborate with Georgian College and RVH. So thank you to everyone and to the audience today. So we had three main research questions for our study, and they're written here. So firstly, we wanted to uncover the experiences and psychological needs of healthcare providers that had arisen from the pandemic restrictions. And this was at Waypoint and RVH. And next, we wanted to discover how the experiences of healthcare providers have impacted professional practices, relationships with their patients, and inter and intra-professional collaborations. And finally, I think the most important, we wanted to uncover types of educational interventions and supports that could address the needs of healthcare providers during the pandemic recovery period. So as everyone knows, COVID-19 created an atmosphere of uncertainty, fear, disruption, and change, both in the general community and in healthcare settings. Understanding and then addressing the needs of healthcare providers can hopefully limit burnout, psychological symptoms, disillusionment, and ultimately support an effective healthcare system. And understanding how the pandemic has influenced professional practice and the environment can also enable healthcare professionals and leaders, as well as policymakers, to offset the negative consequences of the pandemic and help prevent an echo pandemic. And what I mean by that is the mental health residual effects from the pandemic, and prepare for healthcare needs arising from the pandemic. This was a mixed method study. And what I mean by that is that there was two basic components. One was a quantitative portion which dealt with participants answering survey questions on an online platform. So this was questionnaires that had different scales where they would rate their symptom burden or what they were experiencing. And then we had a qualitative component, which allowed participants to speak in their own words what they had been experiencing during the pandemic. And the qualitative portion involved interviews and open-ended questionnaires. In terms of the methodology for the qualitative, we used interpretive description, which is an approach to develop knowledge for a practice and discipline. And the 5 validated scales that we used were related to psychological symptoms and symptoms that we might expect of people during or coping with a pandemic. So the first was a new scale that's been developed. It's called the Coronavirus Anxiety Scale. The second tapped into symptoms of depression, anxiety, and stress, the DAS-21. We wanted to gain a marker of quality of life, so we used the work-related quality of life scale. And then as a measure of resiliency, we used the Connor-Davidson Resilience Scale. And finally, to gauge the sense of loneliness that people were experiencing, we used the UCLA Loneliness Scale. In terms of the demographic characteristics of our population, you'll see among the healthcare providers that nursing represented the largest group. That's the blue in the circle on the upper left. In terms of the age, over half of the respondents were between 30 and 51 years of age. In terms of experience in the profession, it was equal between the different time points you see there. And most people did not live alone. So in terms of our data sources, we collected the interviews and the quantitative results from August to November 2020, and then from January to February. And this consisted of 30 interviews, 88 online questionnaires, and almost 240 psychometric assessments. What's important to note is that when we sampled the Waypoint participants, this was during the summer of 2020 largely, when there was a relative lull in the pandemic, and there was an ease of restrictions. At this point also, there were no COVID cases in Waypoint. But when we sampled the RVH staff, this was at the height of the pandemic, end of 2020, beginning of 2021, when there were a number of COVID cases in the hospital, and the case count in the community had risen steeply. So it's important to note that we sampled these two populations at different times. What we looked to do was to compare the results of the validated questionnaires with benchmark data from different populations in the literature. So what we found that our participants had lower anxiety about coronavirus compared with a general sample of US adults. So at Waypoint, they had lower anxiety. We also found that the Waypoint staff had lower loneliness scores than a sample of US nurses who were employed at a military hospital. The work-related quality of life scale assessed our participants as having a higher work-related quality of life than Iranian nurses who were working in academic hospitals. And then the Connor-Davidson resiliency scale of our sample showed that they had higher resiliency scores than a sample of physicians. Now, again, this might seem counterintuitive that the scores were better than these other populations. But again, you have to remember at Waypoint, this was a relatively good point in the time of the pandemic. And at this point, no one at Waypoint had tested positive for the virus. So the staff were able to conduct their nursing and staff activities as they had before, with the exception of now PPE and some other measures put in place. It was interesting, when we looked at anxiety specifically to COVID, we saw that most people, and again, this is at Waypoint, did not have anxiety symptoms linked to the COVID. However, we did see that there was a portion of the population at Waypoint who were quite anxious. And so we don't want to lose sight of this population when we present just the average results of the sample. So 25% of the population of Waypoint were struggling with anxiety about the coronavirus. And what we found, not unexpectedly, was that healthcare providers at RVH were significantly more worried about the coronavirus than those at Waypoint. And again, there's likely a number of factors that explain this. Again, when we sampled RVH, they were in the height of the second wave, and they were actively dealing with COVID at their hospital. Again, as I've mentioned before, at Waypoint, we were in the lull during the summer, and there were no cases. So it's not surprising that at RVH, they had more anxiety about the coronavirus. In terms of the measures between the other measures between RVH and Waypoint, we found that there was no difference in scores between those two sites, with the exception of the coronavirus anxiety scale. And as I mentioned, the participants had lower depression, anxiety, and stress than a sample of Canadian ICU nurses who had been sampled during the early COVID-19 pandemic. And again, this is not surprising, given that ICU nurses would be in the thick of things, where they would be actively dealing with very serious cases of COVID, dealing with life and death situations, which probably wasn't the case with the average employee at RVH, and certainly not at Waypoint.
Thank you, Nathan. So one of the parts that's really interesting with this study is that it was a mixed method study, as Nathan explained. So what that allowed us to do is to look at the results of these standardized scores, and then use participants' own words to try to understand, what does this actually mean to people? What could be shaping these experiences? And what are the accounts in their own words of what's going on with them? And this is where we start to sort of flesh out and kind of round out the whole story. So Nathan explained that about half of our participants were experiencing reasonably high to very high levels of stress, and the other half were doing okay. So for those who are doing okay, that is great, and there's certainly a strength, but we also want to understand, for those who aren't, what might be going on with them. And so when we did the interviews and when we read the sort of open-ended answers that people gave us, we heard over and over again that COVID fear and COVID fatigue are real and challenging. So the participants explained to us that this concern for contagion, either getting the virus at work or bringing the virus to work, that was actually a story that transcended the 2 time points that Nathan spoke about. So what happened is that even when we didn't have a lot of COVID in August, September, October, people were still concerned about contracting COVID. And what that did is it made the boundaries between home and work really blurred. And it made it really difficult for people to have that inter-shift rest, which, as we know as healthcare providers, is really, really important. The work that healthcare providers do is quite strenuous, it's quite demanding. And to be able to go home and really de-stress and do the activities and be with the people you want to be with and not have that concern was not possible throughout the time periods that we collected data. So that concern, for contagion is big, and it actually creates quite a lot of fatigue. The other story that we heard over and over, and it was interesting how it morphed as time went on, was this heroes to zeros. And a lot of the participants used that word, that little phrase, which I think is important for us to think about. So in the early phases of the pandemic, everybody was clapping for the healthcare providers and people were bringing in, all kinds of recognition. And as time went on, and especially as the number of COVID cases went up, healthcare providers started to be a bit shunned and a little bit ostracized, even by their own social and family groups. People started to get kind of nervous of them, knowing that they were possibly exposed to the virus. So this meant that not only were the healthcare providers really concerned about this, even their usual support systems around them started to create differences. We heard stories of how, some parents didn't want their kids to play with the kids of healthcare providers. They stopped being invited to things when we were allowed to have things, in the different waves of the pandemic. The other part that we heard, again, trying to understand, okay, if like the COVID or the coronavirus anxiety scores were not that high, not as high as we thought that they would be. But what we heard from the participants is that, of course, they're concerned, but they were able to put that in some kind of a perspective using their disciplinary knowledge. They understand infection control. They understand how to use PPE, and they believe that it works because they could see it working. They could see nurses and doctors working with COVID patients and not getting COVID. So they were able to put that in some kind of perspective so that they could manage it. I think in part as well, when you have to go to work every day and work in a situation of COVID, you probably have to put some kind of bubble around it. But what really started to come through, again, beginning when we were collecting data in the early phases, and this persisted all the way through, a key and really strong source of stress and anxiety arose from the professional concern for the patients. So witnessing the patient experiences with the pandemic restrictions, it created distress and what is called empathy strain. So we want our healthcare providers to have empathy. It's essential to have empathy in order to engage in a therapeutic relationship. But when there is so much distress that people are witnessing, that burden can really become quite overwhelming. And those are the stories that we heard. So imagining for example, the psychiatric patients who had severe mobility restrictions because of the pandemic, where they couldn't go to the canteen, they couldn't have group therapy, they couldn't walk the grounds, they couldn't be with their friends. Or on the acute side, watching patients receive either really good news or really challenging news and not having their family with them. So the healthcare providers really became sort of the support system around the patients at both sites. And so much was being asked of them in terms of providing the care that otherwise family members would have been able to provide, or the social support from other patients would have been able to provide that. So it really had a strong influence on the healthcare providers' experience and was very, very impactful. So Nathan, back to you.
Okay. So again, we saw no difference between the two sites in terms of quality of life or resiliency scores. And both sites also had higher scores on the benchmark populations for both the resiliency and the quality of life scores. And again, this just speaks to the fact that overall, they seem to be doing okay, but there certainly were people who were struggling, and you miss those people when you just look at the mean or the average scores. We also did a regression analysis that found that the nursing profession on average reported higher quality of life, work-related quality of life, and greater resiliency than those of other healthcare providers. And there's a couple of reasons why this may have been so. One is that nurses were unlikely or less likely to be redeployed to another setting or responsibility compared with their peer workers, such as those in social work or recreational therapy who may have been redeployed. So in some way, they had more stability in terms of their day-to-day life and their working. And nurses also received training in leadership skills and skills to promote their efficiency on the ward. So this might have translated into the higher rates of quality of life and resiliency among the nursing profession.
Okay, so again, back to this mixed method, trying to understand resiliency scores, trying to understand work life. And it's really interesting what we heard from participants. They did have concerns about the quality of their work life, as I mentioned, connected to all of the changes in the practice environment. But what we heard that I think was maybe having some impact on some of the scores is that they really understood that if they could improve the patient's living arrangements and be able to offer additional therapeutic options within the pandemic restrictions, that they understood that that would give them really professional fulfillment. So there was this hope that these kinds of things could happen, which gave them a certain amount of energy and engagement. And healthcare providers were willing to expand their therapeutic services, and they needed leadership to be able to do so. So we're starting to now drill down a little bit about, what would help improve the work environment and help people to have a better situation at work that would let them kind of catch a break and pull forward their resiliency. Another really interesting finding that I think any of you who are in health leadership positions or do research as I do on interprofessional collaboration, there was a really surprising finding that happened from redeployment, which Nathan mentioned, in both the psychiatric setting and in the acute care setting. Mostly the allied health professionals were required to what's called redeploy. So they had to start either working in different areas or sometimes doing entirely different jobs. And for the nurses, more in the acute side, there was some floating where, as we all know, there was quite a change up in terms of the patient mix, where sometimes elective surgeries were canceled or postponed. We know that emergency room visits have been quite low. A lot of care seeking for chronic conditions has been impacted. So sometimes the inpatient units didn't have the census and nurses would need to float. So this really created quite a hardship. And through the interviews and the open-ended questionnaires, absolutely the allied health had a harder time with this. There was much more disruption to their work life. So then when we think about, resilience and when we think about quality of work life, those really impact the way that people are interacting with the practice environment. And the practice environment really impacts on the quality of care that can be delivered. Whenever workers are less satisfied at work, it absolutely impacts patient outcomes. And absolutely, people were rallying and doing their best to work through it, but it was really tough. But one of the upsides to this is that the participants talked about a much stronger sense of community. They really understood how much they needed each other. And they really, through the redeployment and floating, really started to get a better understanding of the different roles and what each healthcare provider contributed to the patient experience. Sometimes it was because that role was no longer being delivered. And sometimes it was from actually working together. So, for example, if a social worker started providing direct care, that was an opportunity for the social worker or the rec therapist to really understand what is it that nurses do. So it was really interesting. And we know that a foundational requirement for interprofessional collaboration is this understanding of each other's roles and an appreciation and respect for it. And that was absolutely something that came out of some of the changes to the work environment. Another topic that really had a big impact on quality of work life, on resilience, on sort of that internal sense of, the work that I do and how do I feel about the work that I do as a health care professional, came from some of the policy decisions and policy communication and implementation. As we know, there have been many policies developed to keep us safe or to try and keep us safe, to try to manage the pandemic. And as we know, these policies sometimes change, hour by hour. And that was having a really big impact on the healthcare providers. It was doing a few things. One is that when policies were constantly changing, it actually became quite exhausting to try to keep up with it. Okay, well, now what am I supposed to be doing? But it also gave, in a time of high uncertainty and a situation of low control, it actually fed into that because people started to really wonder, well, what is the right thing to do here and what is safe? Because one day they would be told, that patients could be cohorted in this way, and then the next day the policy would change. So they were really unsure of, what was the right thing and what would actually keep everyone safe. The other is around policy, is that participants really want to move away from this emergency crisis mode. I think at the very beginning of the pandemic, people talked about how that first month to 2 months, everybody was kind of, okay, we're in this, we're just going to nail this, we're going to get rid of COVID and we'll all go back to normal. Well, as the months wore on and people realized this is not going away, and then the second wave hit and people realized we're actually going to be in this for a really long time, and we need to find new ways of delivering care for patients. So we need to find new ways of working that are not so difficult for us, because it's not an emergency anymore. It's kind of the way that things seem to be unfolding. So this new appreciation of the interdisciplinary team is really an opportunity to leverage that understanding and that willingness to work together to improve healthcare. And participants were really encouraged by those ideas, and they're really looking for opportunities to find ways to work a little differently, because the current system is quite difficult. So Nathan, back to you.
So again, when we looked at some of these quantitative measures, we saw that there was no difference between sites in their mean levels of loneliness. So this was between RVH and Waypoint. There was no difference in their scores. And also, both sites reported less loneliness than the benchmark population for which they were compared against. So again, it's a bit counterintuitive, but overall it says that the majority of the staff were handling things okay. Again, I don't want to diminish the group or the participants who were struggling, who were feeling lonely, but overall they were faring quite well.
Thank you. So again, we have an opportunity to explore loneliness. And a part of why we decided to measure loneliness, again, it was the time in the pandemic where we were all getting used to, the stay-at-home orders. We were all getting used to living our lives without our friends, really, and without our family and without our usual supports. And I just want to go back to the slide. So we see here at the psychiatric hospital, the loneliness was lower than in the acute care hospital. It's also possible that as time wore on, people were having a bit more loneliness. But in terms of loneliness, when we asked about that, what we started to hear about, and in particular at the acute care site, we started to hear the stories of the taken for granted social support that people give each other at work, the kind of camaraderie, just having lunch together, the quick hallway chats where you might just exchange a quick story. People were really realizing when they couldn't do that. So because people have to keep a 6-foot difference, they weren't able to have lunch together in the ways that they used to. And people were nervous taking their masks off to eat. And we heard stories of people just taking their masks off, really eating quickly so they could get their masks back on, and they didn't want to be in any kind of confined space with their coworkers because they perceived that as a situation of high risk. So what was happening is that kind of support at work was missing. So you heard how the supports at home are missing, we're all living that experience, but at work, people are having that as well. And we heard many, many people talk about how work is starting to feel more and more of a grind without any levity, without any camaraderie, without that sense of fun that you can have on your break time. It was getting to be quite difficult. So Nathan.
Right. So again, when we looked at the differences in scores between the Waypoint sample and the RVH participants, again, this is just a repetition slide, that there was no difference in the scores except for the anxiety over the coronavirus, that scale. So again, it seems even though the two sites were in different phases of the pandemic, they were reporting very similar psychosocial functioning, loneliness, depression, anxiety, stress, except for specific anxiety related to the coronavirus. And again, like I've mentioned before, this is likely due to the fact that RVH was in the second wave of the pandemic, a lot of cases being seen, whereas Waypoint was in the lull and there were no active cases at Waypoint during that time.
You want me to move on, Nathan, too?
Sure. So what are some of our recommendations? So I think right at the top is that understanding sources of stress can advance the conversations and planning with staff. So just recognizing what is stressful to staff and what they are most concerned about can facilitate these necessary conversations that need to take place between staff and the leaders. As well as we need to acknowledge the benefits of empathic responses, because this is something that was really important to the healthcare providers, that they be able to respond empathically to their patients. And when they weren't able to do that, that's when some of these negative sequelae or consequences arose. And supporting patient care outcomes and healthcare practitioner satisfaction are enhanced through supporting IPC. Recognizing the strength and sacrifices of healthcare providers and providing positive reinforcement is another crucial component to this situation. And then engaging healthcare providers in policy development, implementation, and evaluation of programs or new strategic interventions relating to the pandemic and the COVID situation in the hospital. This is also something that's essential to help bolster the psychosocial functioning of the healthcare providers.
Thanks, Nathan. So this is an applied research project where the research questions came from the hospital sites. And so a big important part of applied research is the knowledge translation activity that happens afterwards. So part of that will happen with Marcia after we finish speaking, but I wanted to take you through some of the knowledge translation activity or sort of tools that we developed that could help people implement some of the recommendations. So for example, understanding the sources of stress, we developed infographics that I will be able to show you here that gave an overview of the findings. And as we would have these, we would develop them and then offer them to the hospital site so that the leaders or the team leaders or anyone really could take these and use them as conversation starters. So what we were hearing quite regularly is that people needed more opportunities to speak about their experience, to have that experience validated. And we hoped that these tools might be a way to do that, so that leaders could say, this is what the study is saying. Does this resonate with you? How is your experience different or the same? So we had them for both the qualitative and the quantitative side. We also wanted to show the participants, and this graphic here shows the study in action so that people could see that they weren't just giving data to us and it was going in a vacuum. That's a really important part of applied research projects that the college really supports, is that it really is knowledge for practice, that we ask research questions that have a practical application. And so it was important for us as the study unfolded that we let the participants see what this was looking like to them and where we were at. And if they had questions, they could reach out. And one of the other activities that we did is we call it a Huddle Doodle. So we were experimenting a little bit with this. Again, we were hearing from participants that they needed more support at the bedside where they work. We heard about COVID fatigue, COVID exhaustion. And so to give more for people to do was really difficult. So we were trying to think of creative strategies where people could have things either at huddles or at shift change. And we're going to show you one of the doodle videos that we created that you would be welcome to use if you thought it was helpful. And I think, Daniel, you're going to share it. It just takes a little over, it looks like 3 minutes to watch it. So you can sit back and relax. Daniel, we don't have volume.
Oh, I apologize. Let me start over and see if it works now.
The duration and intensity of the COVID-19 pandemic have created a remarkable strain on the lives of healthcare providers. They cannot escape witnessing the effects of the pandemic restrictions on patients, colleagues, and family members. The isolation, mobility restrictions, PPE, and social distancing create a heavy load for healthcare providers. The suffering, loneliness, physical, mental, and emotional exhaustion can feel devastating. All the while, healthcare providers are striving to give excellent care to patients and remain accountable to their professional commitments and obligations. This is amplifying the effects of the pandemic on them. The ECHO study revealed that healthcare providers are experiencing empathy strain. While empathy is crucial in healthcare, it is critical to maintain the self-other distinction. Practicing self-compassion is crucial to ensure you can have empathy for others. Self-care practices themselves can feel like another item for the to-do list, but a concurrent study revealed the powerful effects of brief mindfulness practices on building resiliency and reducing burnout. An antidote to empathy strain is self-compassion. Self-compassion is a practice and an act of goodwill and invites us to speak to ourselves as we would a friend or loved one. To assist healthcare providers with the struggles associated with empathy strain, we are offering an evidence-based solution shown to assist people to develop resiliency and wellness. Perhaps you can try this strategy today. Today, we invite you to use 2 or 3 moments of hand hygiene to take a self-compassion break. Speak to yourself in the same kind way you would a friend or a colleague. Gift yourself a compliment for the efforts you put forth today. Remind yourself that your best is enough. First, pause for a moment and consider the kindness, care, and compassion you have been providing your closest colleagues when they experience a stressful moment, encounter the death of a patient, or grieve the restrictions imposed on providing compassionate care. What are the things you think, say, and do in these moments to show your care and compassion to colleagues? In these moments, do you believe they've done their best and that their best was enough? Now, hold yourself in this same kindness, care, and compassion. Believe that you did your best, that you did enough, and that you are enough, just as you are. Thank you for the care you provide to yourself and the care that you are providing to patients.
Thanks for queuing that up and just acknowledging our supporters and CERC, our VH Waypoint and Georgian. And I just want to put a little shout out. I think that Laura already mentioned that on June 10th, the other COVID study will be presenting, and the Huddle Doodle was done in collaboration with the other team, Sarah Hunter and her team. So those are the some of the findings that we could condense in the amount of time that we had. And I think we would be happy to take a few questions. What we're going to do is take about 5 minutes of questions, and then Marcia is going to provide some really important strategies that hopefully you can, they kind of respond to the findings that we had from the healthcare providers in our area. And then we'll have more questions once Marcia finishes her talk. So if there are questions now, we can answer a few of them.
There's not any questions right now in the Q&A, but oh, I see Sarah raised her hand. Oh, both Sarahs have raised their hand. Sarah Lankshire, did you want to ask a question?
Yes, thank you very much. Can you hear me?
Problem. Yes, we can hear you.
Okay, fabulous. Thanks very much, everyone, for your presentation. It's really, it's quite wonderful and obviously extremely important work in this at this time. And I reiterate what Jacqueline said, like, who knew we'd be still hip deep in it at this particular point in time. So what I'm really curious about is, what do you might see in terms of the key takeaway messages that when we get out of this pandemic, that we still carry forward for individuals working in very complex, stressful environments? So pandemic aside, I'd really be curious to see how might you be learning from this, but taking it forward when we are again, hopefully out of this pandemic environment. I'd be curious as to your thoughts for that. Thank you.
Thank you, Sarah, and that's a great question. And I think one of the parts that is there are many takeaways, but the one, when I spoke with people, and I think that's where we started to really get some texture to the experience, people who already had wellness strategies, people who were already, engaged in whatever kind of, self-care strategy, whether it was physical fitness, meditation, reading, those people were really relying on those strategies. They had them, they were practicing them already, and they could fall back on them and it helped to sustain them. For the people who didn't have those practices, it was really not now the time to start developing them because their heads were so full, and it felt really difficult for them to imagine taking on some of the strategies that both sites had tremendous wellness approaches. There were lots of opportunities for people, but it was really difficult for people to get going in that way. So I think a key takeaway is that we should not wait for a crisis to support staff to engage in wellness strategies, and that it should be something that we teach in the preparatory education. I think it's something that we have an opportunity to think a lot about as, in the health professions education. I think it's really important in the orientation programs, and it becomes a culture, because surely there will be, I think, long-term consequences, and it will take a long time for people to recover from what they've been through. So we need to think about supporting people to have more self-care, and for the organizations to be an even bigger part of that in the ways that are meaningful for the healthcare providers. That would be one. Nathan, perhaps you have something else?
Yeah, I would echo that. I think going forward for making decisions at leadership levels, that there will be more input, more solicitation from healthcare providers to maybe flesh out some policies or work on strategies that will impact directly the healthcare providers. And I would say too, I think some of the interventions or innovations that took place during the pandemic, for example, just like we're doing now on Zoom, I think we can expect that some of these things will continue. I think, not all of us like Zoom so much, but I think we can expect that we're going to see more of this type of technology, even when we get out of the pandemic. And so it's really revitalized or changed how we go about our daily things by necessity. But I think that we will continue to use some of these technologies, although maybe to a lesser extent for those that maybe aren't the biggest fans of Zoom and these technologies.
Thank you.
Awesome. I'm gonna disable your talking now, Sarah, if that's all.
I won't take it personally.
Sounds good. Alrighty, there's a couple of other questions in the Q&A. Thank you, Daniel, for answering some of those via text. But I'll start sharing some that potentially the other panelists can speak to. The one at the top of the list is What was the sample for RVH nurses versus allied health?
Daniel, I don't know if you can pull that out, or Nathan, if you know it off the top of your head.
So nurses were highly overrepresented in both samples. I think overall it was about 2/3 for each site. So it really was biased towards nursing staff. In terms of physicians, for example, we didn't have any at Waypoint, but we had 10 at RVH. So not a lot of input from the physicians.
So Laura's popped on. I think we'll take more questions after.
Yeah, so I was just going to say, I think that's the last question that we have time for. So for those of you who have your hands up, please put your questions into the Q&A section, and hopefully the panelists can answer them as Marcia does her presentation.
Great. I'm ready to go then?
Yes.
Okay, excellent. Thank you. Thank you so much for that wonderful presentation. And thank you for having me here. I hope the volume is all right. Danielle, is the volume okay? A thumbs up if you're hearing me loud enough? Great. I don't want to shout. Nobody needs to be shouted at. So just on that last point, I can certainly speak to the physician experience. I've been talking to physicians across Canada and even outside of Canada, hundreds, if not thousands over the past year, providing peer support, teaching them parenting skills, stress reduction skills, burnout prevention. So I would say, as was mentioned in the research, some of this is representing that summer lull we had, and certainly right now, tensions are running very high with the groups that I am connecting with. So if any of you are feeling exhausted, spent, sick of homeschooling, having competitions on Zoom with your friends about who has the dirtiest kitchen sink, you are not alone. Feeling a frustrated relationship tension in the home as well as the workplace. Some people are feeling also just blamed and shamed for errors and poor outcomes at work. So that's something that I've been talking to physicians about as well. So again, thank you so much for the clear research. And also we're in a living experiment right now. And I just wanted to connect with each of you as participants that if the tensions are high in your home or for you, you're definitely not alone. And a lot of the groups that I'm running and teaching, they say it's just therapeutic in itself that we're connecting. So I'm a big fan of Zoom because it's been allowing us to connect in these ways. So I will get into a screen share in a moment. And just to let you know, I do a lot of individual work as well as group work. So I'm conscious of every single one of you right now as an individual listening, wishing I could tailor everything I say to exactly your needs. Of course, in psychotherapy, sometimes what one person needs is the complete opposite. So somebody may need to sort of increase empathy, and some people may need much greater boundaries around having extreme empathy, for example. So I'll do my best to try to speak to the variations within the limits, but I really hope that each of you, there will be something in here that can be a takeaway that will maybe change your practice or change what you can do to manage your own stress at home or at work. Okay, so let's start our screen share. So my hope is to help you learn some practical strategies that you can use right away to help reduce stress. And also, there's a path to burnout, right? It doesn't happen overnight. So if you happen to be on the path of burnout, or your colleagues or your loved ones or people at work, patients, so I treat physicians, you may be able to get off that path. And there are some practical ways to do that. By the way, any of the references, I'll talk about videos you can watch or articles or examples of research. I've put all that on my website, drkostenuik.com. Under the More tab, there's all sorts of free resources, book recommendations, technologies I advise. So you don't really need a handout. You can just check it all there if you want. So I like to always fully arrive when we are doing any sort of meeting. So any of you who are leaders or even just participants in a meeting, you can suggest, hey, can we just take a minute or two to fully arrive? So I'll show you an example of how I do that. I tend to close my eyes. So I'm going to invite you now to either close your eyes, or if you prefer, just keep your eyes open with a soft gaze forward. And take a moment right now to acknowledge just whatever's come before arriving here, right? Sometimes before a meeting, there's been a lot of stress, activity, maybe difficult outcomes or surprises, or in some cases, people have been experiencing loneliness. So just allowing you a moment now to acknowledge whatever it is that you're carrying or experiencing before arriving here and what's still lingering there for you. Thoughts, emotions, and just allowing all of that to be as it is. There's no need to clear your mind. You're just simply noticing what's already there with reverence and respect, because it's come up for a reason. This is what's present for you right now. And then I'll invite you to shift your attention to notice your body. So notice your body as a whole, the envelope of your body, your skin, the clothing touching your skin, or the air touching your cheek. And then noticing the fullness and volume of your body. Noticing the contact points with whatever's holding you up, maybe your seat, maybe your feet planted on the floor. And if you can almost witness yourself sitting there, as if you can see yourself there. Inviting you to bring your attention very softly and gently, almost like a feather landing, onto your breathing. Notice what your breathing feels like. Some people like to put their hands over their heart, which is a nice gesture of self-compassion. And even a very slight, gentle smile, just to allow some space for whatever's there to be there. And inviting you to follow 1 or 2 breath cycles, noticing your in-breath and out-breath, just as it is. And then at this time, inviting you to tune in to any sounds that you can hear, just noticing that hearing is happening. No need to judge the sounds in any way. Inviting you to bring perhaps an attitude of gratitude for the ability to hear, which is allowing us to have this experience together right now. And before we close the practice, inviting you to keep this attitude of openness and curiosity and interest into the rest of this session and into your day. Inviting you now to become acquainted with the space you're in, noticing the empty space or the walls around you. And as we're closing the practice now, inviting you to bring a little bit of movement to your feet and toes, your hands and fingers, maybe your shoulders and neck, livening up, bringing in some movement. And as you feel ready, opening your eyes, first to a soft gaze forward and then back to the screen if you are able to do that. Great, and just notice how you feel now, what if it's any different from how you felt before. There's no right or wrong way to feel. It's not really a relaxation practice. It's really a chance to tune inward and just notice what you are experiencing. So sometimes difficult emotions come up for people because they've been blocking that or just too busy to notice. Sometimes fatigue will come up. Some people will feel relaxed or more present and alert. So whatever's come up for you is fine. I'm not monitoring the chat, but you're welcome to share in the chat how you're feeling if you like. And I'm going to ask if any of our panelists are able to come on screen. It would be helpful to me just to partly make sure there's some human contact still out there. Thank you, much appreciated, only if it's possible. And if it's okay, could I ask one of you to just share with the group what that was like to have a brief arrival practice? Oh, is Nathan? I think Nathan's speaking, but on mute. Thanks, Nathan.
Sorry about that. I was just going to say, for me, it was much more invigorating and relaxing than I thought it would be. So I really appreciated this intro into your talk. Thank you.
Great, thank you. So, and that just, I don't know how long it took. Sometimes it's 2 minutes, sometimes it's 7. I enjoy it and I'll keep going. But you can do that in a minute or 2, yeah, with your meetings or at the beginning of your workday to just fully arrive and be present. I actually use a timer every 15 minutes. The bell goes off, and every 15 minutes, I try to come back to that present moment, become aware of it at least, and to breathe. Good. So, learning, if those of you who like learning objectives, I want to help you learn a little bit more about stress, what I think resilience is about, and burnout. Learn to respect your limits and set healthy boundaries for yourself. And I hope we're going to create a new medical culture that is much more sustainable, because as was just discussed, this pandemic is not over quickly, and the echo or waves from it are not going to be over quickly either. And before this pandemic ever hit, burnout rates were very high, 51% for female physicians. So I see a lot of female physicians for stress reduction, parenting, and you're in the minority if you're not burned out at this point. So some of this data was coming before the pandemic. So there's nothing new, but this is an opportunity for us to gain skills that maybe we never had. All of those images will make sense to you by the end of this talk. So I give many different talks, and I've pulled in little pearls and nuggets from all different places to really follow Jacqueline and Nathan's research results, so that this would all be kind of synchronous for you. So you're going to get some of the best or favorite pearls, and I hope that will make it really practical. So the key thing to know about this slide, please don't need to read it all. Burnout doesn't happen overnight. And those kind of 3 key burnout symptoms they always talk about and use on scales, it's very interesting, but to me as a former Emerge doctor, that's like the final MI, right? That's not so interesting to me as acute coronary syndrome or some kind of vague dyspepsia, a stomach upset, which could be a sign of angina, a sign of early cardiac disease. So I'm always interested in what are the early signs and can we catch it there? So for many of us on the path to burnout, this looks like, I love my job. It's awesome. I'm working 24/7. I wake up in the night full of ideas. I have a hard time saying no to things, and I'm not sleeping very well or remembering to eat lunch, right? That's what the early stages of burnout can look like. It's not a sustainable way of working. And as was discussed earlier, those first couple of months, people like me, we hit the ground running. We were on a sprint, but then we sprinted, some of us, for 12 months. That doesn't work very well, right? So we need to pace ourselves. So just be aware, and I'm going to be doing an 8-week program in the fall for physicians on burnout prevention and getting off the path to burnout. I'll mention to you, I'm going to give you for the first time here some of the key areas, so you can look at that yourself and know what are the key things that I think would be practical to help you get off the path to burnout. So some of the many things that can lead to burnout are the way we respond to stress and these acute and now chronic stressors. I think there's a lot of myth around resilience and toughness. And of course, there are system issues. Many people say it's about 80% system issues. So it's a real tragedy when nurses, doctors, or anyone is being blamed as an individual for things that are very multifactorial and related to the system. So when we talk about stress, I think it's interesting that in a sense, there is no such thing as stress, right? There's sort of a stressor, a stimulus, and then there's a response. So what's stressful to you might be fun for me, and what's stressful to me might be something that doesn't bother you at all. So we've got these acute stressors, but then we have chronic stress, right? So what happens to our system when it just isn't relenting? And that's so much of what's happening right now. So I don't know about you, but I am not a huge fan of getting hundreds of new emails in my inbox. So for me, that would be a stressor. This guy looks quite happy about it. Maybe he's got some music on and he enjoys the email. She's looking very distraught about it. So this is what I look like when I get that many emails. So that's a stressor for me, for sure. So what's going on when that happens, right? So we've got this system that's designed, we know, fight, flight, flee, and some other responses that I'll talk about in a moment. And we're ready to run. And so I'll be at my desk with emails or whatever is going on, PowerPoint, and my heart rate will go up. I'm getting ready to run, right? This is not necessary. But the system is designed for it. It's sort of this old system. And now we're dealing with new stressors that didn't exist way back, right? We didn't have email. We didn't have technology. We didn't have 24/7 kids wanting to use YouTube and gaming and that kind of thing. So our system's being bombarded. A lot of people are having visual problems right now, right? From so much screen time. You know, you're supposed to look up now and then. I'm lucky I have a window, so I can look right now and see the furthest into the horizon, just to give your eyes a rest even. So lots of things are triggering a fear response for us right now. Did you know, I think 70 to 80% of us have email apnea, so I'm not alone. We stop breathing normally when we're checking our email or doing any of that kind of work. So on my website, I put this easy breathing video, a link to it. I think you can train yourself to breathe. I actually have run this in the background of my email, and it has a sound, and you can start remembering to breathe while you're doing your work. So that's a very practical thing for those of you doing a lot of work on screens. So how do you respond to stress? Like I said, I wish I could speak to each of you as individuals. Some of us get into high gear. Some people shut down. They're overwhelmed and they just kind of, I call it flop. They sort of flop. They just cannot cope. They need to be activated. And then tend and befriend. I've done a lot of this over the past year. I've met so many new friends and colleagues. So one of my responses is to connect with people. This can be very adaptive. So depending on how you're responding to stress, so of course these are meant to be adaptive. So there's adaptive responses and maladaptive. So if you need to flee, then this is adaptive. If you need to connect, this is adaptive. But sometimes we develop them in maladaptive ways. I think this is so important because it's not just enough to tell people, do restorative yoga, do breathing techniques, do some mindfulness. And those are all things that I teach, by the way. But some people actually need activation, right? So if you're in fight, flight, and revved up, let's do the breathing practices. Let's bring it down. Let's calm the nervous system and soothe it. But if someone is shut down, and even some kids, a lot of people I've been talking to, their sons have been not doing very well. They may need vigorous exercise. They may need scheduling of fun activities, right? Behavior activation. And then many of us need to connect more. And the more we connect, we feel better. If you go for a walk with a friend when we're allowed to at a distance with a mask on, you usually feel a lot better afterwards for a whole bunch of reasons, the fresh air and sunshine and exercise as well. But we forget how good it feels to connect with friends. And I'll bring that up again because that's a really helpful practical thing. So one of the things that happens neurobiologically, Daniel Goleman, who wrote the book Emotional Intelligence, calls it amygdala hijack, right? We get hijacked. So not only are we in fight flight mode, but it shuts down this prefrontal cortex, so to speak. So less electrical activity, less blood flow, and less functioning. And these are super important functionings. I'll show you in a minute. So this is when you kind of snap, or you just say things you wish you hadn't said, you behave in a way you wish you hadn't behaved, and you kind of feel like people will say they were out of their mind, or what were they thinking? And they weren't thinking at all. They weren't using the prefrontal cortex. So we realize, oh, that was inappropriate. So I teach a lot of work with that in parenting and mindfulness, how we can learn to calm and respond rather than be so reactive. So I think of the amygdala hijack as an alarm bell or a fire alarm, but it's like you've burnt toast in your kitchen and you need to kind of stop the alarm from ringing, right? It's not functioning anymore. It was helpful initially, but we need to be able to turn it off or slow it down. And as I said, the prefrontal cortex does all these important things: empathy, insight, response flexibility. I think that's huge, right? To be able to not just be black and white in your thinking, morality, right? Intuition. So these are very important functions that are getting hijacked. I like to think of throwing a bucket of water on that response. And so when I developed psychological first aid tools, the first three, the A, B, and C, are intended to kind of quiet that down. And that's awareness, similar to what we did in that arrival practice. B is for breathing, and I'll show you an example. And C is for counting. It's a grounding technique where you count things that you can see and hear and feel. So I pulled a little bit of that into the arrival practice. So that's the ABCs. And then 1, 2, 3 are cognitive functions, and those are not going to work very well until we've quieted down the amygdala. And I'll show you that in a minute. So what can you do to be more resilient truly? Mindfulness and meditation practice will thicken the prefrontal cortex and can shrink the amygdala and reduce reactivity in the amygdala. And the Dalai Lama challenged neuroscientists years ago, say, study our brains, you're studying sick brains, but what about ours with tens of thousands, 80,000 hours of meditation? And sure enough, there were very significant differences in the prefrontal cortex and amygdala. And amazingly, in just 8 weeks of mindfulness training, these changes start to appear in participants. And we're finding even in less than 8 weeks now, this is being reported. This is the Muse, M-U-S-E, Muse biofeedback headband for meditation. I love this. I use it. I've used it off and on for years. So that's an option that you might like to try. Things like Headspace is a great app for your phone. If you want to exercise, so I sometimes put an exercising person like lifting a dumbbell for your bicep. Will it work? Yes, it will work. I've never seen this not work. Just like if you lifted a dumbbell regularly for 8 weeks, you would have stronger biceps. So that is, I think, a very helpful way to become resilient. If you want to print or download the tools I developed, they're on my website. You can just print them and use them. You can stick them on the bulletin board at work or put them in your lab coat pocket. A psychoanalyst friend of mine said they should be posted on the back of bathroom doors. So you can just walk through these. You don't need any fancy training. I do an hour and a half training, or I do an hour peer support with the CMA. Those are free for physicians to join and medical students and residents. So, I do like to train and do peer support with them, but you can just read this through and use it right away. And I'll give you a few highlights from it today. So so the ABC I mentioned, 1, 2, 3 is one. What is the one next thing for you to do, right? Not 10,000 things, just one thing. What are 2 strengths that you have? And 3 things you're grateful for, and you call those things to mind. So it's very quick. This is listening. So the large tool is more for counseling, listening, answering, and problem solving, which is a suicide prevention strategy. R is for red flags, who needs referral to more than just first aid. G is group and connecting, and E is to engage. Check in on people, follow up with them, especially physicians. They don't ask for help. If they do, I always like to follow up. Even if it's a friend or a text or an email, I'll check in the next day or a few days later to see how they're doing. Let's do some box breathing together. So the Navy SEALs also use box breathing, and this is in the tool in the ABC, so it's the B. And when I mentioned to you about email apnea, this is the M-Wave. This is another biofeedback. So this is some of the technology I recommend that people can try. You don't need to spend a couple $100s on this. I already bought it, and I'll prove to you this is my results right here. It works. So I plugged it in. I started doing my regular breathing, and I'm pretty trained in breathing for meditation. And I got this beautiful sine wave right off the bat. And I thought, oh, this thing isn't working. That was too easy. So then I started doing my paperwork, and I got this totally not coherent signal. And then I went back to doing my breathing, and I got this beautiful sine wave again. So guess what I was doing while Nathan and Jacqueline were presenting? I was doing cardiac coherence breathing, right? Why not? I can breathe and listen at the same time. So I'm going to walk you through one example of cardiac coherence breathing, which can just be regular, smooth breathing in through your nose and out through your nose for a 4 count in, 4 count out. This box breathing, you actually hold it at the in breath and you hold it for the out breath. This can stop panic attacks. I've used this with patients with panic attacks, panic disorder, borderline personality, people who are dysregulated and feeling overwhelmed. This is extremely helpful and so easy to do. Some physicians I've talked to now are their patients on telemetry. They get them to box breathe and they actually can see the changes on their heart monitor and slowing of the heart rate. Okay, so after your next exhale, I'm going to count you now. So breathing in, 2, 3, 4, hold it in, 2, 3, 4, breathe out, 2, 3, 4, hold it out, 2, 3, 4. Breathe in, 2, 3, 4. Hold it in, 2, 3, 4. Breathe out, 2, 3, 4. Hold it out, 2, 3, 4. Breathe in, 2, 3, 4. Hold it in, 2, 3, 4. Breathe out, 2, 3, 4. Hold it out, 2, 3, 4. Good. So you are getting this lovely sine wave, most likely, right now in terms of your cardiac coherence. It's sort of like your heart and your breathing and your mind, everything is coordinated. And if you do that every 15 minutes, you can't get too far gone into anxiety and distraction. Or if you do that once a day, it would be helpful. If you do it at lunchtime, or you do it at the beginning of your day or before bed. In the tools, so ABC 1, 2, 3, that was part of it. In the large tool, LARGE, G is for group. So connecting in groups is really important. And this is one of the things that was spoken about in the research. So loneliness, right? So people talk to me that they just can't seem to connect. So I'm a connector of people. So I just kind of throw out examples of things that seem to be very helpful. Call it once a week, have a call with a friend. Doesn't have to be the same friend. You don't have to wear someone out, or it could be the same friend, but aim for at least once a week, a phone call where they can hear your voice. Voice will help co-regulate and create calmness. If you're anxious and you have a calm friend or a very rational friend, that can be extremely helpful. Maybe reconnect with old friends. I've even reconnected with an old high school teacher recently, and that was quite delightful. So connecting outside of work is important so that you have some relationships with people who have a different perspective. I've hosted a social hour with one of the groups that I'm on. So alternate to the meetings or committee meetings every month. The 2 weeks after that, I host a social hour. And when you look at management literature, what you find is that water cooler talk is actually crucial, not just for our mental health, but it improves other very hard outcomes for businesses. So for hospitals, nurses, clinics, you're going to get a lot of important information that's going to be passed at a social time, not just at work. And as Jackie mentioned, that's been eliminated, a lot of that water cooler talk, hallway talk, those little brief things. Just invite people. If they don't come, they probably still feel good. Like some people like declining the invitation. Not that they like declining it, but they like knowing they were invited, even if they can't come. Or even if they aren't wanting to come. Physical contact, so that with the people you can connect with, make it count. Be attuned. I'm trying to look into my camera right at you, right? Like that you really see the person and you're delighted to see them. And you notice how they're feeling and how they're responding. You're not distracted looking at your phone. Smiling more, smiling co-regulates. If you put on a slight smile, this is really helpful. And some hospitals have used large name tags. I love this idea. I want to do it when we're out with a mask on. If you wear a name tag with yourself smiling and you could see your face really big, this would be very helpful rather than everyone looking kind of scary with a flat face. If you look up on Google, still face experiment, it's incredible. Even babies respond to a still or flat expression. It creates a stress response. It looks threatening. So a slight smile is very helpful. Create your own club. If you're good at cooking or you like a certain kind of artwork, you can always create your own club. So those are some of the ideas to battle loneliness. So like I said, faces, this is huge. You can't help this. This reaction happens emotionally and physiologically. So even cognitively, if you know someone's nice, but they look angry, your sweat glands, cortisol levels, heart rate, everything is going to get activated. So be responsible with your facial expressions. Practice a slight smile, not phony. I think this smile here, this young woman looks a little bit forced. So we're very good at detecting a not authentic or genuine smile. So try in the mirror, if your flat face looks a little bit lips turned down or you look angry, you can try putting on a slight smile, and sometimes a slight smile just brings you to kind of neutral. So you can play around with that and see. And that's, I mean, right now with a mask on, it's not going to help a lot, but the times where people can see you without your mask. There's attend and befriend, right? They feel good and happy together. So sometimes fear it's just adaptive. And I spoke to a hospital recently with very high numbers of COVID, and they're afraid about adverse outcomes, mistakes, getting blamed, getting shamed. And sometimes the fear is real. I mean, that's a whole other talk. But in those cases, I teach to use wise mind, right? What's rational? What is emotional? And what does your gut tell you? And there's a lot of detail. I do whole sessions just on wise mind, but it's a great, you can Google wise mind and you can learn Marcia Linehan's DBT version of wise mind. So really bring to mind, what are the facts? What is the real danger? What is the real risk? And you may need to get help. You may need to call for, medical legal help, or talk to a very trusted colleague who you can speak to in confidence. So sometimes our fears, such as those, are just real, and they need to be validated and understood. Pandemic fatigue. This was, I believe, a Scientific American article this year, where people are exhausted. They're just sick of restrictions. They're sick of, my home, I'm teaching algebra 1 minute and I'm running a meditation and the dog's barking and I'm trying to get dinner. My husband works from home. I work from home. It's chaotic and people are just feeling exhausted. So in some cases, they're not complying as well with some of the pandemic guidelines because they're just tired of it. They've used a term in that article called immersive multitasking, and this was spoken to in that research. So, people don't have a real definition from work and home, and they're doing all sorts of things at the same time. It's leading to exhaustion. So one of the strategies I would like to share for that, and there's some of the things that I use or recommend, is to create some boundaries if you can. So some of you, we're talking about clinical work, but some people are doing quite a bit of work from home. So right now, actually, I have my time timer right here on, and time timer is used also for kids with ADHD. It can be used for patient encounters. So keep track of your time. And if you say, I'm going to go for a walk in 15 minutes, put the timer on, because an hour later you will have forgotten. But if the timer goes off, you also have to respect the timer. Or if my kids want to see me and I say, I need a half an hour or give me 10 minutes, I set the timer and try to stick to it. This is a sound machine. So if you're working from home, I have my sound machine at the door right now. Then I can't hear as much of the other activity going on, or the kids. Even putting cloth over a door or a French door, absorbent cloth or towel, felt, will help reduce the sound. And this is just the actual, I tried to find a picture and I thought I'll just take a picture of my own door. So these are from my own door. This means I'm in session and don't knock on the door or come barging in. I also lock my door. And this means I'm done at 5:15 because I forget to get up when my timer goes off. I'll keep working. So they know at 5:15 you can come and get me and I'll start cooking dinner, or I'll come and go for a walk. Maybe try closing time. So put a real end to your workday. Don't just let it drag into 6, 7, 8, 9, 10, midnight, 2, 3 in the morning. So what about having a closing time where you literally shut everything down? Do you ever do that? Shut down all the devices, the computer, the screen, push your chair in and shut the door and leave it behind. You can do this as a ritual. You can even, that'll be my next one. I learned this from karate. You bow out of the dojo, right? You bow in, you bow out. So you can have some kind of practice, some kind of reverent practice that is thankful or grateful. It could be at your clinic or your hospital. In the psychotherapy office, I enjoyed the days I would remember to bow out with some grace and thankfulness and respect for what went on in that therapy room, right? Very meaningful conversations, tears, important things that had transpired. So just to acknowledge that and then to let it go, right? You can even do a physical practice with boundaries. You breathe in and you kind of breathe out and put your arms in a big round circle around you. You can wash your hands, and as you rinse your hands, you can let go of whatever stress, whatever's you're still carrying that you feel ready to let go of. You can let that go as you wash your hands. So you could use something symbolic and meaningful to you to put a lovely end to the day or to your shift. So this was brought up in the research, and it's a favorite topic of mine and favorite topic of many of my students. I often think of this as empathic resonance, where somebody else's emotions are activating something in you. So to me, the idea of empathy is you feel a little bit of what somebody feels. I call it like dipping the toe in a swimming pool to feel how cold it is, right? You get a little taste. Some of us have a lot of empathy, an empathic response that's very even overwhelming. And some people have very little. But also what can happen is it activates other feelings in you, right? So if this is an example where a kid is angry at the parent or angry in general, and the parent could be noticing, oh, they're angry, but sometimes the parent is saying, oh, they're so disrespectful. They shouldn't behave like this. What's going to become of them, right? How are they going to turn out when they're older? This is all my fault, right? So all these other things are coming up in you, and this resonance happens, and it can become quite overwhelming. So it is important, and even just this little visual drawing to remind ourselves. And when you're with a patient or with someone who is very activated and you're starting to feel that, you can almost picture the little dotted line. I think of it as a semi-permeable membrane of a cell, right? Some things go in and some things don't. So picture this boundary and see if you can notice how they are feeling and focus on what is it that they're feeling? And then you can notice, what am I feeling? Is it a reaction or is it a little bit of what they're feeling, right? What's mine and what's theirs? Can you be mindful of that in the moment? It's tricky because we get amygdala hijacked quickly sometimes. So an example would be your patient is very sad and they just feel hopeless and helpless. And here's a woman, she's actually got her arm, I think, around her elderly mother, but she's showing compassion. So this to me is someone caring about someone else, not drowning in overwhelm and feeling equally hopeless and helpless, right? That's not helpful anymore. Empathy is helpful if you dip your toe in the pool and you get a taste for what it is. And then that information allows you to respond in a way to reduce the person's suffering, right? So I'm hopefully you can still hear me. Okay. So to me, that's the value. If you're emotionally overwhelmed and now you're helpless and hopeless feeling, you can't do very much to help the other person. So I teach convert your empathic response, emotional response, to compassionate action. Just a small thing you can do. An emergency doctor once taught me, sometimes the best thing you can do on a night shift is give a patient a warm blanket. So that's an act of compassion. As an emerg doctor, I've seen it where, you know, a patient was in pain or distraught, or maybe with dementia and yelling something out, and you feel terrible because you're walking by and you can't do anything. Maybe it's not your patient. Maybe there's nothing that's making a difference right now. So that warm blanket was either symbolic or literally an idea of what could you do to help reduce the suffering. Why is this so important? With empathic fatigue, what happens is empathy is giving a pain signal. If you're feeling a little bit of someone's pain or a lot of their pain, you're getting a pain signal. If you do something compassionate to reduce someone's pain and suffering, you actually get a reward signal, a dopaminergic signal. So you feel good about it and it won't exhaust you. So we don't fatigue from compassionate action. We fatigue from this empathic resonance. That's the way I see it. A great sage was asked, what is your secret? And he said, do you want to know my secret? And the surrounding audience said, yes, we want to know your secret. He said, when it rains, maybe some of you know this, I let it. Right. Wow, right? What if it's raining for someone else who you care about? Can you let it? I teach this as with the child, the angry child, can we let them feel their feelings? Right? Without putting our fix-it hat on and telling them what they should or shouldn't think or feel and what they should do. Can we let people feel their feelings? Can you let someone's sadness be there? As a yoga instructor, we learn this. It's called holding the space, right? As a psychotherapist, holding the space in meditation. Can you hold some space and just allow the feelings to be as they are, because they've come up, they're valid. We're validating that. We're not saying it's wrong or you shouldn't have it. And often we do that because we don't want to feel bad, right? We want to make it go away because we're feeling it too. So I think, well, could you just have a little umbrella? Because I'm not too fond of standing out in the pouring rain. And I think of an umbrella as that little bit of compassion. Is there a little something that we could do to try to reduce the suffering? So I think listening, which is part of my tool, LARGE, L-A-R-G-E, the LARGE tool, listening is therapeutic in itself. So don't underestimate, as a nurse, as a physician, as a psychiatrist, any of us, as a parent or a friend, listening is therapeutic. It's just one of the best things we can do for people, especially if you're attuned and you're present and you're making eye contact. And if you know that that is something, it's not nothing, that's helpful for those of us who want to do something, right? We want to act, we want to fix it. So I just wanted to make that really clear. This is a form of compassionate action. And because Jacqueline presented that lovely video and is going to be offering you more resources on mindfulness, which I think is so appropriate, I thought I would share, I added this in, it's something I teach in my mindfulness and meditation series. Towards the end of the series, I teach the loving kindness, or the Pali word is metta, so loving kindness meditation. And I'll just give you a visual. I'm very mathematical. So if I think of a baseline and below the baseline is suffering, compassion brings you up towards the baseline, right? You're reducing suffering. Loving kindness could be thought of as adding kindness or happiness, trying to add kindness and happiness. So it's kind of above the baseline. So compassion, I think of as reducing suffering, and the loving kindness is trying to add this feeling of wellness and happiness. So this is an evidence-informed practice, meaning there's research showing that this works very well at a bunch of different levels. And if you want to practice it, you just repeat phrases that are loving kindness phrases, whichever phrases work for you. Some people don't like the phrase, for example, may I be happy, because there's just so much sadness going on, and it doesn't, it's not validating how they're feeling. So you can use whatever phrases you like. These are some examples. And I like to add a qualifier to whatever degree possible, because some of you might be working, for example, with a patient in palliative care. So to just say, oh, may you be healthy, it might sound not appropriate, but to say, so let me just give you, I'll model it to you. You could repeat it 3 times for yourself, and then 3 times for somebody that you care dearly about, and then repeat it for someone who's neutral, like a neighbor or a colleague. And then you can repeat it for someone you find very difficult to connect with. And then you can extend it to all beings. Right? So this is a practice. It's more of like a mantra, you could think of it. It would be similar if people are praying, this could be similar. So I have a colleague, and if I was stressed, he'd say, I'll do some metta for you, which is not unlike someone saying, I will pray for you. So I just thought this may suit some people and not others. And for those who it may suit, I didn't want to leave it out. So let me just recite a couple phrases for you. To whatever degree possible, may I be safe. May I be healthy. May I be peaceful. May I live with ease. To whatever degree possible, may you be safe. May you be healthy. May you be peaceful. May you live with ease. So this could be done as, again, for someone who feels there's nothing they can do. I thought this could be very helpful for people to have something where they feel that at least I can do that. And again, the evidence shows that it is very helpful. This, the monk in the MRI, this is the fastest way to activate positive sort of happiness circuitry, is by having the monks think about this type of practice and generosity. So this is a very science-based approach. So what do I think of resilience? Resilience is important. I talked about, I think, these practices, so thickening the gray matter in the prefrontal cortex, that's probably true resilience, shrinking the amygdala reactivity, not being so reactive. And there are practical behavioral strategies, but this curve, the Yerkes-Dodson curve from, I think it's 1908, was first described. The idea is that higher levels of arousal can increase our performance, right? When you're half asleep at work, you're not going to perform very well. But if you are over aroused, too stressed and activated, this can actually reduce your performance. So we want to be in this comfort zone. And my teenage son said, well, Mom, what's this line? I said, well, that's what companies and organizations, they say, we want to increase resilience. We want to increase performance. So we're trying to squeeze a little bit more out of our workers or out of ourselves, which for maybe a few weeks, days, weeks, or maybe months at the beginning of the pandemic, we can try to squeeze out some high performance. But over time, what is this really doing? So I'm concerned about some people's ideas around resilience. Resilience really means the ability to recover, right? If a piece of metal is resilient and you bend it, it bends back, right? That's what we mean by resilience. We don't really mean to be squeezing out higher performance, but I think sometimes those concepts are getting confused. So I'm not trying to train anybody to be a superhero. When I get physicians with burnout and I teach them all sorts of skills and strategies, sometimes I say, oh, you're using my skills for evil. They're using it to increase their performance. And we were just trying to buy time until they could unload and make a more realistic schedule and work with some of the underlying personality traits that lead to burnout. And I'll show that next. So some of us are wired for burnout and we will just keep heading there unless we deal with some of the underlying factors. So some of us are superheroes. We want to help everybody all of the time. Workaholic, which I actually call work use disorder because it acts more like an addiction. And the physicians I work with are typically in denial. And I really have to work to break through that very carefully. And often they'll come back later and thank me and say, thank you so much. I was completely in denial. And they know how difficult it was to get through that. So work use disorder, meaning if people try to cut back, they seem to keep working too much again. It's having negative consequences on their physical health, mental health, and relationships, but they keep doing it, right? So it's acting that way. So it's not cute to be or funny to have a workaholic personality. I take it very seriously. Perfectionistic. I love the quote from John Steinbeck, now that you don't have to be perfect, you can be good. A colleague of mine wrote an article called The Good Enough Doctor in response to the similar article, not in a response to, but in the same vein as The Good Enough Mother, which relates to Winnicott's work on attachment. So that's, I won't go deep into that, but just knowing that being good enough is really helpful, much more helpful than being perfect. And as clinicians, being good enough is tricky because it does have to be good enough. We have to meet appropriate standards. And that's something I work one-on-one with physicians on, is how can we still meet good standards and do good work, but not the perfectionism that can lead to burnout. Lone Ranger, meaning we don't ask for help, right? We try to do it all on our own. So a physician recently said, I was trying to talk to doctors about burnout and resilience and some of the best ones, and figuring out what they were doing. And I said, well, what did you find out? He said, they were burning out. I said, that's what the research shows. The best employees, so the ones who don't say no, they take on more work, they stay late. So people who don't have healthy boundaries, sometimes we think those are great employees, but it may not be sustainable and it certainly may not be healthy for them. So I was a bit wanting to caution around this idea of recognizing your colleagues' stress and sacrifice. So as long as we don't reinforce it as be a superhero, exhaust yourself, that's great. And I don't think that's what is meant at all. I think what we're meaning is to be appreciative of one another's work. So I hope we'll encourage people when they take a break or when they take a holiday, and good for you for, setting limits. So I think we should recognize people also for limit setting and remember that concept of being good enough. So just reminding you with this curve, I think we need to stay in this more sustainable zone. Some people get depressed if they're not doing enough. And also people with ADHD, I find it can be, they like to work right at that kind of high adrenaline level. And this pandemic might be pushing a lot over the edge. So I think at an individual level, I think of this metaphor of a truck and how much load it can bear. And many times when I work with individuals with burnout, they have overloaded it. I constantly risk overloading this with all sorts of different jobs and projects. And then you look at the whole system, right? What can the whole system hold and bear, the system that you're working in? So I think it's the combination of those that we have to look at, because like we said, 80% of burnout may be related to system factors. And then the fourth dimension, time. right? How long, right? So I took on a huge load early on, and then I never cut back, right? I kept going and going and going. Well, it was never, there was no way that was going to be a sustainable pace. It's like in track and field where you learn to pace yourself for the 800-meter race or for a marathon. You can't start with a sprint, but we started, some of us, with a sprint. We didn't know it was a marathon. So now needing to do some recovery. So sometimes it's just too much and things start to fall apart. And how much can you bear? I put laundry, cooking, work, bills, all that kind of stuff. And then all of those resilience factors. So Jacqueline mentioned people who were already meditating and doing exercise and had practices. It was helpful. The doctors I talked to, a lot of them stopped everything. They stopped all that good stuff. They started working more, and some of them started sleeping less and also drinking more alcohol. So not helpful ways of responding, and now leading to burnout. So really good supports in your culture, your medical culture, your workplace, your system could really reduce a lot of the issues of burnout, because you're going to have a lot more strength around the individual. I think of culture as traffic here too, right? Like just so much going on. What is everybody else doing? And if everybody else is acting like a superhero, that's going to be problematic. So if there are system problems, let's not blame the individual and make sure that we're looking at system solutions. I loved what Jacqueline mentioned about nurses having training in leadership. How wonderful, right? So they're using these skills. So I teach what I call empower skills and diamond skills. And those are two different series of skills that talk to these ideas of leadership skills and emotional intelligence and boundaries and assertive communication, right? The kind of leadership things I think that you're talking about. And that skill training can be extremely helpful when there's a lot more stress going on. So just realize that some employees will take on more share of their responsibility and they will burn out. So the ones who can't say no, and if you keep asking them, they will burn out. So you lose your best that way. And the individual skill, I would invite any of you who are the person who has a hard time saying no, your skill building is going to be around assertive communication and learning to set limits and boundaries and sticking with them. So myths about resilience. I love that your research showed nurses were already very resilient or more resilient than others. Physicians are also very resilient, and they have high ACE scores, meaning adverse childhood events. So they have higher than expected adverse childhood events, given their kind of socioeconomic demographic statistics. So they also tend to have a lot of resilience. So I think resilience is part of the problem leading to burnout. I, for example, am very flexible. I used to dance, I do yoga. And before my yoga teacher training, I did lots of yoga and I strained my hamstrings. And I read online and I learned from experts that it was going to take something like 8 or 9 months for this to recover. And I thought, no way. I used ice, I used all the things I could do. And guess what? It took 9 months, right? There was no way around it. So hyperflexibility, hypermobility in some people leads to physical injury. And with resilience, sometimes we just keep piling it on. So some people have been noticing that these really, the most resilient doctors they know are the ones burning out now. So again, we've got to be careful of what we mean, the terminology around resilience. And I think we have to be kind to ourselves when burnout symptoms are happening and we're not acknowledging them, and there is that denial. So I'll tell you, in terms of questionnaires, one thing that I've been hearing, so on burnout questionnaires, some physicians, it's kind of like ego protection and identity protection. They can't even acknowledge to themselves that they have these symptoms, and so they'll say no. Right? No, I don't have that, because they don't want to believe it themselves. This is part of the whole denial problem with workaholics and with physicians being superheroes. So interestingly, I believe there's going to be some underreporting on burnout, because who wants to brag that they have burnout symptoms or even admit it to themselves? And then if they don't, they can get into those end stages of burnout where people will just collapse. So like I said, some of us these are called dually trucks, I think, with the double wheels in the back. They're super powerful. and we will overload them. Most trucks on the road are overloaded. I've learned that there's electrical systems that are supposed to prevent this, but people cut the wire. So if you're working an emergency, if you showed up at work and they weighed the truck to see if you were overloaded and you had cut the wire, they would need this foolproof system. And then they're working on this. This was from an engineering article, actually, literally on trucks. So I think humans need to have this safety measure in to make sure we aren't going in overloaded, as most trucks are overloaded. Imagine if we had to weigh in that way every day. So I want us to move to resilience. From resilience, sorry, to recovery. So, or as part of your resilience language. And I was so glad to hear that Jacqueline said this is, very commonly known to her, that we need to recover. You need to recover after your shift. And like she said, we're not recovering now, because then we're homeschooling and then we're doing cleaning chores and all sorts of other things, extra things that have been added to us. So the program that I'm developing is called Recharge. And, each letter, again, it's a mnemonic for different steps. I think I'll show that to you next, actually, because it might be helpful for you to just know what they are. And then maybe you can just integrate some of those yourself. So resilience alone will not charge a battery. Batteries take time to charge. And they need to be connected to an energy source. So I think you can get that metaphor pretty clearly. So first, recognizing the signs, that energy management, and I use some technology to help monitor that. I'll show you that in a moment, and I want to make sure we're okay on time. Connecting socially, especially outside of work. You've got to have a hobby or a life, something outside of work. That is very helpful in terms of risks around burnout. Activity, like we said, behavior activation, getting moving once your energy is recharged. It might be hard to do that initially. Renewal, growth, and then emerging in whatever way, right? Whether it's back in the same work or you've continued work, or whether you're in a new role or something new altogether. So we emerge. So like I mentioned, I like to use technology to help us. So the HRV, heart rate variability, is the difference between the beat to beat variability. And there's an app called Welltory. I think you can get a free version, Welltory. I really like this app. So I check my battery, my human battery. Am I charged or not? And if I'm charged, it gives me a nice green with a full volume. But if I'm drained, it says I'm strained and drained. So now I know I need to recover and I need to look at my schedule and I might need to cut back on a few things. This night, it told me I should go to bed or my stress levels may go haywire. So I did. This is what I noticed on my phone that was monitoring me all along. So before the pandemic, my heart rate was pretty smooth. And this was what happened in 2020. I'm sharing all my personal stuff here with you. That's something I teach with speaking. I think speakers need to be a little more personal during this pandemic, to be real, because we're all just feeling very exhausted and isolated. So I'm sharing this with you. Heart rate warnings, none. I never had a heart rate warning in 2019. And then the pandemic hit and high heart rate warnings. So remember that tiger slide, me sitting at my desk or doing a presentation or getting emails done? You think a tiger's chasing you, but it's not. So that's where now I've learned to do the breathing practices and remind ourselves we're safe. I use a sleep app called Auto Sleep, AUTO Sleep, Auto Sleep. I don't know if that's free or it might be an inexpensive app. And I noticed people on the forum talking about the effects of alcohol. One standard drink, so like 4 ounces of wine will actually wreck your sleep. So it can shorten the sleep and it will reduce restorative sleep. So people will wake up earlier than usual. So they think that it's helping them fall asleep, which it might be, but there can be a lot of adverse consequences on restorative sleep. So that's important to keep in mind. Now, if your calendar is completely packed like this, you may need to be setting some limits, right? If you don't, you might burn out. And then all of a sudden limits are made for you because now you can't function. So I would rather you look proactively at your calendar and see if maybe it's time to make some adjustments. One of the things I teach with assertiveness and to be proactive with setting limits is to say no. right? You don't have to be on every single group and committee. Maybe there's one that's really important to you. And if it's that important, then you can say yes. But for some people temporarily, if they're burning out, the default mode can be changed to no for now, or for a year, or for whatever length of time you need. You can learn to say no kindly. You don't have to be mean, right? Thank you so much for thinking of me. I'm flattered that you would like me to chair this committee. I'm not able to do it at this time. Maybe next year I would check in again, something like that. So try to say no kindly if that suits you. And not only are you likely to burn out with a schedule like that, but you don't have time for the people who love you. You don't have time for friends and family or sleep. So I actually worked at writing work on all of those little books. So that was me putting in a little bit too much work. Work, 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 work. No life outside of work. That's not healthy. And then you lose your identity. And if something does happen with work, people, physicians particularly, can really fall apart because they've not developed a life outside of their work. That can be very hard at retirement time for physicians as well. So I hope you'll make some space to enjoy and savor what you already do have in your life. And usually after I do any of these talks, I go and spend some time with my kids, some quality time, good eye contact, maybe play cards, or just see how their day is going. So I hope you will make a more sustainable schedule for yourself. I give doctors a prescription for play. I have written this right on the prescription pad. The trick is there can't be any purpose to it. And I tend to always try to throw some purpose. Even when the kids were little, I would joke that I'd be organizing the toys rather than playing with the toys. So, you know, it should be something that has no purpose other than to just have fun and be playful. That picture, the black and white, is Bertrand Russell, and I love his quote, and I had written this and put it in my bathroom years ago. It says, "One of the signs of an approaching nervous breakdown is the belief that one's work is terribly important." And I love that quote. And he's a Nobel Prize winner, right? John Steinbeck is a pretty good writer, the one who said, you know, now that you don't have to be perfect, you can be good. So these two individuals had a real insight that, as extremely important as their work might have seemed, they had a perspective that there is something more, right? So I think that's me using my time timer to make sure, and we're good, we're on time. I'm practicing what I preach. Hobby outside of medicine. Do you have a hobby outside of medicine? I used to have tons of them. It's come way down, but really it's a must. We need something that we can enjoy and get our mind off of work. It's not enough to just kind of finish work early. What else are you going to replace your mind with? So the research presented today really spoke to that. What Jacqueline said really spoke to this, that you know, to go home from work and now, like, my husband used to play hockey. He doesn't have his hockey anymore, right? So while you're playing hockey, you're not thinking about work. You're not thinking about anything about other than that puck, right? So a lot of us have lost those things. So we need to come up with new activities. One of my kids promised me for my series I'm teaching to come up with, and she's like, I'm going to make an exhaustive list of like every hobby you could think of. And I said, well, that will be great, because there's so many things people could do. So I hope you have learned some skills to understand what stress is, what it's doing to your mind and body, thinking about resilience in different ways, understanding burnout and that it's a path that doesn't happen overnight, so it can be prevented, to respect your limits, set some healthy boundaries, and maybe together, all of us can use some of this new languaging and approaches to create a culture that's sustainable, and we will move from resilience to recovery, from superheroes to sustainable, and from empathy to compassion. I hope there was something in there for you. Thank you.
Thank you, Marcia. Nathan, I wondered if you wanted to make any closing remarks, or if we have time for questions. I don't know, Laura, I'll leave it to the two of you.
I think we have time for one question. So I think the most upvoted question is there a value to helping folks think about the relative risk and stress of the pandemic? That is to say, with utilization of evidence-informed infection control practices. Is it possible that the relative risk is lower than the level of anxiety might suggest?
It's very interesting because we heard both sides to that. You know, people did have the disciplinary knowledge to feel protected from the PPE, and yet healthcare providers are amongst the group who are the most infected from COVID. So I think that when people can use the PPE as it's intended, absolutely, but things happen sometimes, you know, when workplaces are overstrained. So I think it was a double-sided, you know, people did believe in the PPE, but then when their coworkers would get COVID at work, it would really start to create this cycle of, well, you know, what was it? And I think it's also difficult. It's a really complex question. And Marcia, you talked about the blame and shame, because that's the other part. So when someone would get COVID at work, there would be this, well, what didn't they do? And so it's a really complicated kind of set of circumstances around that we probably would need a lot more time to really dissect it. But I think it's a really interesting discussion about how do we support people in those protective mechanisms. And it's interesting because some of what we've been talking about, and I think some of these are not the findings, and what we're doing here today comes out of the study data. You know, these weren't our ideas going into the study. These are the things that participants talk to us about needing. And I wonder if when we think about PPE, if we could also think about some of these sort of self-care strategies as part of our PPE, because I wonder if sometimes we go into a cycle of sort of fear and concern, and it makes us even hard to use some of our disciplinary knowledge. I don't know if I said that eloquently because it's complicated, but I think that there's multiple forms of PPE, I guess, that can help us to feel safe at work, including, you know, the mask and goggles, and including some of these protective strategies that Marcia has walked us through.
Oh, Nathan, you're muted.
Marcia, thank you so much for an enlightening and just really refreshing and useful talk. I know I'll be checking out your website. There seems to be so much good material on that. And I just want to thank you for helping make our Waypoint Talks series just so much more special. So thanks on behalf of the whole Waypoint and Georgian team here for coming to our talk. We really appreciate it.
You're welcome, and thank you so much for this opportunity.
Great.
And thank you to all of our panelists for a great presentation today. The chat is filling up with thank yous from our attendees. So once again, I would like to remind everybody that this recording will be available on YouTube at a later date. We will send out an email to all registered participants when that is available. And feel free to share it out to anybody and everybody afterwards. And then we will also send out an email with a participant satisfaction survey, and we encourage you to give us your thoughts on this session, as well as any suggestions for future sessions that you'd like to see. So thank you to all of our panelists once again. Thank you to all of our wonderful participants who joined us. And hopefully we will see you at the next one. Have a great day.